So when we do the radial EUS, we talk about stations. When I'm teaching my fellows, I talk about doing stations when examining the upper GI pancreatico-biliary system. And why do we have stations? Well, the thing that is static in everybody is blood vessels. So whether or not somebody has a small pancreas or an absent gallbladder or two kidneys or a horseshoe kidney, I know that everybody has an aorta. I know that everybody has an IVC. I know that everybody has a portal vein and a splenic vein, you know, within reason, of course. And I know generally where all of those things are, and they don't deviate very much in the average population. Those things aren't going to deviate. And so we rely on our vascular anatomy to then help guide what should be around those vascular structures. And so on the right here, you'll see that I have them numbered 1, 2, and 3. Those are the stations when I'm teaching that I have my trainees position their echo endoscopes, and in each station, we should be able to identify some blood vessels and the adjacent structures. And so we'll just go through a couple of them just for demonstration. So for example, here we're sort of in sort of station 2 almost. We're in the duodenum. The echo endoscope is in the duodenum. We're almost at the papilla, maybe just a little bit before the papilla. And typically what I know I'm going to see there is I'm going to see a lot of shades of gray, which I know everybody sees there. But I know with certainty there should be a vascular structure, a large black vascular structure that exists there, which is going to be the portal vein. And the portal vein is the marriage of the splenic vein and the superior mesenteric vein. And so sometimes I'll see those two things come together and form the portal vein. And you know, it's not as easy, and my fellows will attest to this, it's not as easy as just putting your scope there and voila, there's the image. There's a lot of nuance, there's a lot of detail of how you maneuver your endoscope. Are you torquing your shaft to the right or to the left? Are you applying some tip deflection with your wheels? Are you suctioning the air, because we know that air will distort the image? And so there are a lot of practice that needs to go into finding these images, but ultimately we get the same image. So on endoscopic ultrasound, I'll have the pancreatic structures here, and then I'll have a large black portal vein there. And so then I know I'm in the right setting for examining the structures around the duodenum and the pancreatic head. And then if I begin to pull back, you know, and come back along this cartoon, I know that posterior to the duodenum, sort of in line with the portal vein, there should be another anechoic structure, meaning black, nothing in it, and that should be the common bile duct. And again, this cartoon here shows it nicely, where the two are sort of running parallel to each other, and then we get the image together on endoscopic ultrasound. And then if I maneuver my scope a little bit more, perhaps torquing it in an anti-clockwise direction, I'll maintain those two structures, but then I'll be able to sort of follow up and find another black structure here, and that black structure should be the gallbladder. Now, you can argue that the gallbladder can be on the underside of the liver, or it can be to the left or to the right, but again, in general, it'll be accessible from this station in the duodenum to be able to assess the gallbladder. And here we're probably more in the duodenal bulb at this point. And then ultimately I'm able to track through that common bile duct. And this is what we did this afternoon, is when we find the common bile duct, we're able to trace along its extrahepatic course, so we can follow it all the way down through the pancreatic head to the ampulla or the papilla, and then track it all the way back up to the liver, where it begins to bifurcate into the hepatic ducts. And that allows a very detailed, highly accurate assessment of the bile duct to look for stones or strictures or tumors. And again, same thing here. So, you know, if I were to show this cartoon here, we have a pancreatic head. There's our pancreatic head. I have a large vascular structure, which I know is the portal vein. And then I have two smaller anechoic structures, you can see, that are not turning red on my Doppler window, which is this portion here. This is a Doppler window. This is not turning red, so I know they're anechoic but not blood-filled, and so therefore I deduce that they're some sort of other fluid-filled structure. And so this is the common bile duct on the top and the pancreatic duct on the bottom. And if I push in further, and I want to go assess the underside of the pancreas, so the uncinate process of the pancreas, I'm able just to know that by pushing my endoscope down here, I'm now close to two structures, the aorta and the IVC. I know that they're behind the pancreatic head, and so we will see the aorta, and closer to the probe, I would see the IVC. And then on the other side, I would see other important vascular structures. And if I see that image, I know that what should exist between those vascular structures is the pancreatic head or the uncinate process. And so I'm able to find the vascular structures first and then zero in on the pancreatic uncinate. And so this is just a brief video trying to highlight this. So this is that pancreatic head station. So I'll have a black vascular structure here. This is the portal vein. This is the pancreatic head here. This is the common bile duct. And so this was my fellow who was scanning through, and he was very happy to find the common bile duct. He was thrilled, and I think he was ignoring the very large bright. So this is hyperechoic. So you can see that very nicely. This is a hyperechoic structure. It is brighter than the adjacent pancreas. And you can see actually here that the echoes are coming off of the probe, and then you see it turns black here. We call this a dropout. So this is so dense that it's highly reflective. It's bouncing right back, and we're losing some of the image beyond it. So it's a shadow, and that's a common bile duct stone. So this is a stone that was in a young individual that was perhaps moderate probability, not ready yet for an ERCP, but we did an endoscopic ultrasound, found the stone, and then appropriately sent them over for ERCP. When we come back into the stomach to examine the pancreas, it's not all that different. Again, we rely heavily on vascular structures. We know that the pancreas tends to drape itself behind the stomach and head upward to the left upper quadrant toward the spleen. And when the endoscope is in the mid portion of the stomach, I know that I should find an important vascular structure, which is the splenic vein, which is this black structure here. And this splenic vein, again, will marry the superior mesenteric vein to become the portal vein. But once I find the splenic vein, I know that the pancreas will exist between my probe and the splenic vein in everybody. So as soon as I find the splenic vein and I have my probe, I know that the pancreas will be somewhere in between the two of them. And then as I track that along, I know if I just simply pull back and follow that pancreatic duct, I can pull back, and find two important structures that shape the tail of the pancreas, which are the spleen and the kidney, and I know that the pancreatic tail should be between them. So it is much easier to find spleens and kidneys sometimes than the small pancreatic tail, and I'll use my vascular structures to find the pancreas first, and then go find these other important organs and track the pancreas in between them. And so again, a short video to highlight this. So this is that splenic vein structure here. And again, if I find the splenic vein and I have my probe, I know right between it should be the pancreas. This little structure that you see wisping through it is the pancreatic duct. We have the liver up top here, the gallbladder. But really what I'm focused on is the pancreatic body. And so by using those vascular landmarks, we can examine the pancreas thoroughly and completely with the echo endoscope. Now, what about the linear EUS scope? So again, it provides that wedge view. It doesn't allow us to see a 360-degree view, but you can use the torque of the endoscope to sort of see the entirety of the surrounding tissue if necessary. But really, the main advantage are interventions, fine needle interventions, and so. We use fine needle aspiration or fine needle biopsy. The two are distinctly different, but are largely interchangeable when we talk about them. And it involves the sampling of structures by passing a needle through the endoscope and into our endoscopic ultrasound window so that I can see the needle as it comes out, and I can direct that needle with very fine certainty. So I can miss blood vessels by millimeters, and I can enter tumors to take a biopsy that would otherwise prove quite challenging if it were to be done transcutaneously via CT guidance or something like that. Again, primarily used for for intervention. Some people still do use it a lot for diagnosis. I certainly will use it for diagnosis in a lot of settings, but the understanding of the anatomy is a little bit more difficult when it's not 360 degrees, because it does require a little bit more maneuvering of the endoscope to achieve some imaging of the adjacent structures. And so that this one can take some more time to learn and understand during training.